Listos.
Hola, buenas noches a todos. Bienvenidos una vez más a nuestro webinar semanal sobre diabetes e insuficiencia cardíaca. Vamos ya muy avanzados en este curso. Estamos en la 10ª sesión de 12 en total, o sea que estamos muy cerca de completar este webinar que ha sido exitoso, de llamar mucho la atención, de 2 temas de mucha actualidad. El día de hoy vamos a seguir con el capítulo 3 o el módulo 3 que habla de la utilidad de los métodos de imagen en pacientes con diabetes y con insuficiencia cardíaca. En esta ocasión nos va a tocar hablar de las aportaciones que la cardiología nuclear, básicamente con técnicas PET y PET, pueden ofrecer al paciente con estas dos patologías. Y para eso contamos con un ponente muy importante, es el doctor Robert Miller, que nos acompaña de Canadá. El doctor Miller es jefe del Departamento de Cardiología Nuclear en la Universidad de Calgary para que nos comente los aspectos más relevantes de esta patología. Me permitió invitar a 2 colaboradores muy cercanos de nuestro departamento para que una vez que terminemos esta plática del doctor Miller, hagamos la coordinación, las preguntas, los comentarios que sean necesarios, y será la doctora Isabel Carvajal y el doctor Giancarlo Rojas, ambos médicos nucleares especialistas en cardiología nuclear, quienes comandarán mucho esta discusión de un tema que espero resulte muy interesante para todos. Así que bienvenidos y empezamos. Marcos, si podemos empezar la ponencia del doctor Miller. Y una vez más, bienvenidos a todos. Gracias.
I'd like to start by thanking the organizing committee for inviting me to give this talk for you today. My name is Dr. Robert Miller. I'm a clinical assistant professor at the University of Calgary, and I'm the director of nuclear cardiology and cardiac CT. I'm going to be discussing the role of SPECT and PET to evaluate the progression of diabetes and heart failure. I have no relevant disclosures for this talk. So this is what we're going to cover today. I'm going to talk about overall population trends in heart failure and diabetes, which hopefully you've seen before, but also in nuclear cardiology and how they interact. We're going to talk about the yield of SPECT and PET in patients with heart failure or diabetes. We'll talk about risk stratification, targeting revascularization, and then very briefly, we'll talk about viability imaging. So hopefully you've seen a slide similar to this in one of the other talks as part of this session. So this shows the percentage of patients with diabetes in the United States, and you can see that it's been steadily increasing since the 1950s. We see similar trends in the prevalence of heart failure, but what's worth noting is that it's primarily been increasing as a secondary diagnosis during hospitalization. So it's increasingly listed as a comorbidity, but the absolute number of patients admitted with a primary diagnosis of heart failure was stable, at least in this one study. So again, this is US data. So how do diabetes and heart failure interact? Again, hopefully you've seen this data before, but diabetes is a consistent risk factor for the development of heart failure. In the Framingham study, the relative risk for heart failure in patients with diabetes was 1.8 for men and 3.75 for women, with similar results seen in the Heart and Soul study, MESA, and Haynes. Not only is diabetes a risk factor for heart failure, but heart failure is a risk factor for diabetes. And that's because up to 60% of patients with heart failure have insulin resistance, and about 2% of patients with heart failure develop diabetes per year. Over on the right hand of the screen, you can see a schematic of how diabetes leads to heart failure. So it can lead to heart failure through epicardial coronary artery disease leading to ischemic cardiomyopathy. But there are also mechanisms that are independent of epicardial coronary disease, and that's related to cardiomyocyte hypertrophy, activation of the RAS system, autonomic dysfunction, abnormal calcium handling. But what's really missing from this diagram is that endothelial dysfunction and microvascular disease are also quite prevalent in patients with diabetes, And these can contribute to the development of both ischemic cardiomyopathy as well as non-ischemic cardiomyopathy. This is a review published by Dr. DeCarli's group, and I put it here mostly to highlight that only 5% of the total coronary artery resistance is related to the epicardial coronaries. So although all of our imaging focuses primarily on epicardial coronary artery disease, 85% of the resistance is actually related, 95% of the resistance is related to the microvascular system. And there can be structural abnormalities as well as functional abnormalities, both of which are more frequent in patients with diabetes. So those are the trends for heart failure and diabetes. What have the trends looked like for SPECT imaging? So firstly, the prevalence of ischemia has been steadily decreasing since the 1990s. We think that's primarily related to improvement in medical therapy for patients with stable coronary artery disease. So while the prevalence of ischemia used to be close to 30% of studies, it's now close to 5%. And the percentage of studies that are abnormal is now under 10%. So in the overall population, the yield of SPECT imaging seems to decrease. Looking at PETs, there has also been a decrease in the number of studies that are classified as ischemic, but it's less so compared to SPECT. And that's partially related to patients' characteristics leading to selection for different testing. But again, the trend has been a decrease in the number of abnormal or ischemic studies. So we have diverging trends. The proportion of patients with diabetes is increasing, prevalence of heart failure is increasing, but abnormalities on SPECT and PET seem to be decreasing, SPECT more so than PET. So do these two trends counteract each other such that SPECT and PET may be helpful in patients with either diabetes or heart failure? So let's take a brief break for a case. This is a 58-year-old woman with a history of atypical chest pain. She described it as non-exertional burning chest pain lasting for 5 to 10 minutes at a time. Past medical history was significant for diabetes, hypertension, and dyslipidemia. She didn't exercise stress, SPECT MPI. She went 7 minutes on a burst protocol and developed dyspnea only. This is her resting ECG. It's essentially normal, except there's T-wave inversion that lasts through more of the precordium than would be expected. This is at 7 minutes of exercise. So now she has some upsloping ST depressions and leads to an AVF, and she has some horizontal ST depressions of 1 to up to 2 millimeters over in the lateral precordium. Her changes resolve quickly with recovery and are now upsloping just at 30 seconds into recovery. We get CT attenuation imaging for all of our patients. So you can see that she has coronary calcification in the LAD. She also had coronary calcification in the other arteries. We find this quite helpful in deciding whether or not findings are real or would be related to artifacts. So this is the gated SPECT study. So what you have here is you have the rest imaging on the right, the stress imaging on the left, and you can see that there's a post-stress wall motion abnormality with hypokinesis of the distal anterior wall and apex, as well as the anteroseptal segments. So again, these are the apical slices, and these are the more basal slices of the gated images. Here you have perfusion. So I'm showing you the attenuation corrected images. So stress and then rest, stress and then rest. And you can see that there's a stress induced abnormality in the distal anterior wall anteroseptal segments. We use quantification for all of our studies. So we also looked at the polar maps, and you can see that there's a reversible defect that's present in the distal anterior wall that involves the apex and wraps around to involve the distal inferior wall. And over here, you can see using quantification by total perfusion deficit, which just quantifies deficits relative to a normal database of polar maps and quantifies both the extent as well as severity of deficits. This says that the stress defect was 11%, rest defect was 2%, so 9% ischemia. If I was going to score this with some stress scoring, I would have scored it as a 7, and I would have scored the rest as normal. So relatively similar quantification with some stress scoring and TP. The patient went on for coronary angiography. She had non-significant disease in the RCA. And in the LAD, you can see that she had a significant mid-LAD lesion. She received a stent and symptoms improved. So what's the yield of SPECT and PET imaging in patients with diabetes? So this is the DIAD study. They included over 1,100 patients. They randomized them to stress testing, and the primary outcome was either death or non-fetal MI. So 520 patients underwent pharmacologic stress, SPECT MPI. 22% had abnormalities. So again, compared to the 5 to 10% that we see with SPECT, the percentage of patients with abnormalities with diabetes is roughly double what we expect in the rest of the population. They also found that patients with a moderate or large defect had an increased risk of the primary outcome with an adjusted hazard ratio of 6.3. The other thing they showed is that there was no difference in outcome according to screening, but there was also no significant difference in medical therapy or revascularization between the arms. So the argument could be made that if you were more likely to change your management based on the results, then maybe you could demonstrate a benefit. This is more data from Dr. Burke. So it was 575 consecutive patients with diabetes referred for SPECT MPI. 29% were asymptomatic, and they looked at the prevalence of either any ischemia or more than 10% LV myocardial ischemia, which would be classified as moderate to severe. And patients with diabetes had significantly higher proportion of ischemic studies. So again, compared to 10% in the overall population, across all of these important subgroups, the prevalence of ischemia is closer to 20%. What about PET studies? So again, this is looking at either symptomatic or asymptomatic patients with diabetes. It's from Dr. Patel. And the prevalence of either any perfusion defect or any ischemia is again closer to 20 to 30%, which is significantly higher than the overall population. So that's for patients with diabetes. What about patients with heart failure? So this is a study that looked at 376 patients with heart failure. Every patient underwent coronary angiography. They demonstrated significant coronary artery disease in 255 patients. There was nuclear testing in 101. They found it to be 83% sensitive for coronary disease, but also demonstrated that there were abnormalities in 81% of patients. So if you look at patients with heart failure and preserved ejection fraction, you're more likely to have abnormal findings on your SPECT, especially compared to the overall population, where again it's closer to 10%. So who cares if you find something abnormal? Did it make any difference if you were going to go fix it? So this looked at whether or not the patients had revascularization and whether or not they had coronary disease. So in patients with heart failure, preserved ejection fraction, patients with coronary artery disease were more likely to have a drop in their LV function over time. And as we know, LV function is a good predictor of mortality in patients with heart failure. But what they also demonstrated was that if you underwent revascularization, you were less likely to have a decline in your LV function over time. So maybe you could use SPECT as a gatekeeper for pursuing coronary angiography and deciding who should be revascularized. What about PET in patients with heart failure and preserved ejection fraction? So I'm not going to talk about relative perfusion because really that's very similar to SPECT data, but this looks at quantification of myocardial blood flow, which is MBF, as well as myocardial flow reserve, which is just the ratio of your stress to your rest myocardial blood flow, and it's a measure of how much you can augment myocardial flow. So patients with heart failure, preserved ejection fraction are the blue bars. Patients with hypertension but no documented heart failure were the red bars, and normotensive controls were green. And you can see that the stress myocardial blood flows are lower in patients with heart failure, preserved ejection fraction, and the difference was more pronounced for myocardial flow reserve, where you can demonstrate significant differences in patients with heart failure preserved ejection fraction compared to the control. What about patients with non-ischemic cardiomyopathy? So this is 73 patients with HFF with normal regional myocardial perfusion, and decreased myocardial flow reserve was associated with abnormal diastolic function and associated with left atrial strain. So a little bit more about coronary flow reserve. So coronary flow reserve is the same idea as myocardial flow reserve. So this looks at coronary flow reserve in patients with ischemic and non-ischemic cardiomyopathy. Again, this is from Dr. DeCarli's group. They looked at 510 patients with LVEF less than 45%. 380 were ischemic, 120 were non-ischemic, and that was adjudicated by blinded physicians. And they demonstrated that global coronary flow reserve, which again is a different word for myocardial flow reserve, was lower in patients with ischemic cardiomyopathy, but they also demonstrated that abnormal flow reserve was common in both patients with ischemic as well as non-ischemic cardiomyopathy. We're going to come back to this study again later, but again, the takeaway point is that abnormal myocardial flow reserve is common in patients with heart failure, either ischemic or non-ischemic, and heart failure preserved ejection fraction or reduced ejection fraction. So overall, there's a larger proportion of patients with significant abnormalities on nuclear imaging when you look at patients with either diabetes or heart failure. Many of those patients lack classical anginal symptoms, and a lot of those studies you saw that the patients or proportion of patients with diabetes who were asymptomatic was 20 to 30%, but they still demonstrated significant abnormalities on SPECT imaging. PET myocardial blood flow quantification and myocardial flow reserve can identify additional abnormalities by studying the microvasculature. And we see abnormalities in HFpEF, HFrEF, ischemic cardiomyopathy, and non-ischemic cardiomyopathy. Another break for a case. So this is a 57-year-old gentleman with newly diagnosed heart failure. He had an ejection fraction of 20 to 25% by echocardiogram, no history of hypertension, diabetes, or dyslipidemia. He also did an exercise stress SPECT MPI. There were no significant ECG changes, and he developed dyspnea at 6 minutes on a Bruce protocol. This is his CT attenuation imaging. So he had extensive coronary artery calcification. And here I'm just going to jump ahead to the perfusion imaging. So here I'm showing you again the attenuation corrected images, and you have stress and rest, stress and rest. And these are all short axis slices going from the apex to the base. Here you have the vertical long axis, stress, rest, horizontal long axis, stress and rest. And what you can see is that there's a partially reversible defect in the inferior wall. It's a non-transmural defect in terms of the rest imaging, and that there is still some uptake. But on the stress study, there's almost no radiotracer left in that inferolateral wall. And this is a pattern that we commonly see in chronic total occlusions of any artery, where you see a fixed perfusion defect with peri-infarct ischemia. This was his gated imaging. It may look like it's not moving, but really what it shows is that the ejection fraction was severely reduced, and the EF that was calculated from this was 20%. And again, we like to use quantification in our lab whenever possible. So here you have a polar map, and you can see again that there's a partially reversible defect in the inferolateral wall. And total perfusion defect was 22% at stress and 19% at rest. So again, that fits with a primarily fixed defect with a small amount of peri-infarct ischemia. So what did his coronary angiography showed? Well, this was what would have been expected based on that defect. So there's a occluded right coronary artery that you can see fills slowly by some collaterals. It's really gone. The other thing that we demonstrated was that there was an occluded or nearly occluded obtuse marginal branch as well, both of which could explain the territory of the defect. And you can see that the RCA is filling via collaterals. So this patient was sent for revascularization on the basis of ischemic cardiomyopathy. They did do a FFR of the LAD and it was non-significant, so he went for stenting. So now we're going to start talking about risk stratification. So this looks at patients with diabetes, and they looked across different severities of perfusion defects. They included 1,271 patients with diabetes and 5,800 patients without diabetes and followed for almost 2 years. The primary outcome was death or non-fatal MI. And they demonstrated two things. Firstly, patients with diabetes were more likely to experience the primary composite outcome across all of the perfusion defect severities. But they also demonstrated that perfusion defect severity could risk stratify both patients with diabetes as well as without diabetes. So this is data from Dr. Berman's group. So they looked at 6,000 patients, 1,200 with diabetes, and they stratified across whether or not the SPECT study was normal or abnormal. And they also separated out insulin-dependent diabetes, which is the white, non-insulin dependent diabetes, which is the white bar, from patients requiring insulin, which was the dashed bar. And they demonstrated that, again, patients with diabetes were more likely to experience events. But they also demonstrated that the nuclear test could risk stratify both patients with diabetes or without diabetes. They went on to look at how much of the risk could be explained either by clinical factors or by considering diabetes or adding in the nuclear perfusion findings. And both for death or MI, they demonstrated that the model was really improved most by the nuclear test findings. So again, SPECT provided very robust risk stratification in this group of patients with diabetes. So what about looking at total perfusion deficit? So as I said, we use a lot of quantification in our lab. So total perfusion deficit compares the stress and the rest polar maps to a database of normal polar maps to quantify defect severity. So this was a study from Dr. Slomka's lab that included 20,000 patients. There were almost 3,000 with diabetes. And diabetes was associated with an increased risk of MACE in the overall population as well as across each of the perfusion categories, with the exception really of patients with totally normal perfusion. So this is less than 1% stress perfusion deficit. There was no difference in outcomes between patients with diabetes and without diabetes. But as you had increasing total perfusion deficits with stress, the difference in outcomes in patients with diabetes became more apparent. And also there was an increase in risk for both patients with diabetes and without diabetes. So people have performed similar studies looking at the use of PET in patients with diabetes. So this included 7,000 patients, almost 2,000 with diabetes. And in patients with diabetes, abnormal perfusion was associated with increased risk of cardiac death with a hazard ratio of 4.4. And PET improved risk reclassification for cardiac death with a net reclassification index of 0.39. And you can see across all of these important subgroups, there were no significant differences in the ability to risk stratify. And although this error bar crosses 1, the actual interaction p-value was not significant, suggesting that even in patients that are under age 55, it's able to provide some degree of risk stratification. This looks at the ability of coronary flow reserve to predict abnormalities. So they looked at two components. They split coronary flow reserve in the lower, middle, and upper tertile, but also looked at total perfusion deficits, either greater than 10%, 1 to 9%, or less than 1%. And they demonstrated two things. Firstly, increasing perfusion deficit was associated with increasing annualized mortality, but they also demonstrated that adding in the coronary flow reserve information improved the risk classification, such that if you had normal regional perfusion, but also normal coronary flow reserve, your outcomes were excellent. But if you had abnormal coronary flow reserve with abnormal perfusion, your risk of mortality was close to 10%. So this is a separate study, not specifically in SPECTR PET, but looking at the presence of microvascular disease as a predictor of outcomes in patients with diabetes. So here, microvascular disease was the presence of microvascular complications, so retinopathy, things like that. And they demonstrated that patients with microvascular disease were significantly more likely to develop heart failure as an outcome. So here that circles back to the pathogenesis of how heart failure and diabetes interact. And again, diabetes is associated with significant microvascular dysfunction. And here it's demonstrating that the risk of heart failure is significantly associated with presence of microvascular disease. This is another study from Dr. DeCarli's group. We showed you the first results previously, but here I'm just showing that coronary flow reserve was a significant independent predictor of events with a net reclassification index of 0.381. So not only can you identify abnormalities in coronary flow reserve in both patients with ischemic and non-ischemic cardiomyopathy, but you can also stratify the risk for MACE or cardiac mortality. So what have we said so far? Patients with diabetes, myocardial perfusion scan provides robust risk stratification. Even minimal defects with quantitative analysis are prognostically important, and you can reclassify risk compared to standard assessments. And looking at patients with diabetes with microvascular disease, you can also predict risk of progressing to heart failure. What about in patients with heart failure? Well, nuclear cardiology provides risk stratification in both patients with non-ischemic and ischemic cardiomyopathy. So a lot of the nuclear world is really focused on the results of the ischemia trial, and it was certainly a very important trial for the field. So this is a bit of background. This is the original work by Hakemovich et al. Paved the way for pursuing the ischemia trial. So this looked at a large database of patients who underwent SPECT MPI, and they looked at the interaction between revascularization and the proportion of patients with, the percent myocardial ischemia. So they demonstrated that there was a significant interaction with revascularization and percent ischemic myocardium, such that the more ischemia you had, the more likely you were to derive or to benefit from revascularization. Again, this was a retrospective study, so you can demonstrate correlation, but you can't demonstrate causation. And they demonstrated that the curves crossed at about 10%. That's why the ischemia threshold for the ischemia trial was set at 10% ischemic myocardium. This is the baseline characteristics from the ischemia trial. I just wanted to highlight one thing. There's a large proportion of patients with diabetes in this trial. So almost 40%, or over 40% of patients had diabetes. The other thing I want to show is that the percentage of patients enrolled based on stress imaging was 75%. So most patients had stress imaging, a small proportion were enrolled just on exercise tolerance tests. But in terms of the question about heart failure for this study, The ischemia trial was mostly patients with normal ejection fraction. So this looks at the characteristics of patients who were approached and then enrolled. And what I wanted to highlight here is that the majority of the patients who were randomized in the nuclear group had moderate or severe ischemia by stress imaging. So this KM curve is for the primary outcome, which was cardiovascular death, myocardial infarction, hospitalization for unstable angina, heart failure, resuscitated cardiac arrest. So lots of different components. And they demonstrated overall no benefit to invasive therapy compared to conservative therapy. So again, the ischemia trial was a trial comparing intervention strategies, not imaging strategies. And the imaging component was really to select patients they thought were most likely to benefit from revascularization. If you look at the outcomes at 4 years, there was a slight decrease in the primary outcome. So 2.2% less likely to have their composite outcome at 4 years. And you can see that the curves are continuing to diverge. And some people are calling for extension of the follow-up of the study, which might reveal significant differences. The major secondary outcome was a composite of cardiovascular death or myocardial infarction. And this was briefly going to be the primary outcome of the study. And here you can see again that 2.2% decrease at 4 years, which was then statistically significant for the major secondary outcome. But looking at the overall risk, you have an upfront risk of events in order to prevent long-term risk of events. This forest plot just looks at important subgroups. I just wanted to highlight a few. Some patients did not meet core eligibility for the ischemia trial in the core lab. They were still included in the study. And there seems to be a difference in potentially the benefit of revascularization. The other group that's worth looking at is the group that had none or mild ischemia on the core laboratory assessment. Again, that was on the side of favoring conservative strategy, whereas patients with moderate or severe ischemia were on the side of favoring invasive strategy. But these interactions were not statistically significant. I just wanted to highlight a few things about the outcomes. So if you look at the different types of myocardial infarctions, if you look at procedural myocardial infarctions, this really drove the upfront risk in the invasive group and then stabilized over time. Whereas looking at spontaneous myocardial infarction, you can see that it's significantly higher in the conservative group and was lower in the overall invasive group, as well as patients managed with either PCI or bypass. So really what you were doing with the invasive strategy, at least in my opinion, was you were trading upfront procedural myocardial infarctions for prevention of spontaneous myocardial infarction during follow-up. This is some data I put together again with Dr. Berman's lab, but we were looking at a larger proportion or larger population of patients with SPECT imaging and looked again at the potential benefit of revascularization. But we looked separately at early revascularization with PCI and early revascularization with bypass. And the reason why we did this is the revascularization strategy in the ischemia trial wasn't randomized. So we were trying to see if there was a reason to believe that there would be a difference with either PCI or bypass. So here what we demonstrated was that, again, there was a significant interaction between the MACE benefit of revascularization and ischemia, such that patients with more significant ischemia were more likely to have improved outcomes with revascularization. We demonstrated a slightly different crossover threshold and demonstrated really the significant results were only in patients with severe ischemia, so greater than 15%, with a trend towards benefits between 5 and 10%. So what have other studies shown in patients with diabetes specifically? So this looks at the Berry 2D study, which looked at freedom from MACE in either PCI or bypass. So here they demonstrated significant improvement in event-free survival in patients with diabetes who underwent bypass, not necessarily with PCI. So again, this conflicts with our data from an overall population. But potentially in patients with diabetes, bypass provides more benefit. The other thing I wanted to highlight, so this is work I performed with Dr. Slomka, is because SPECT MPI interpretation is inherently subjective, we wanted to see if you could select patients for revascularization with quantitative assessment of ischemia. So we used ischemic total perfusion deficit. So again, that's a method of quantification comparing to a normal limits database, and demonstrated that patients with greater than 10.2% ischemic EPD were more likely to benefit from revascularization. So the thresholds were slightly different, and potentially you select a different patient population using automated quantitation compared to subjective quantification. This work looked at the same concepts by using coronary flow reserve. So they looked at patients who either had low coronary flow reserve or normal or high coronary flow reserve, who underwent medical therapy or revascularization. So patients who had reduced coronary flow reserve, regardless of revascularization strategy, were more likely to experience events compared to patients with preserved or high coronary flow reserve. But what they did demonstrate is that patients with coronary flow reserve that was reduced had significantly improved outcomes with revascularization. And they also went on to look separately at PCI and bypass. So patients with coronary flow reserve that was low, that underwent coronary bypass grafting, actually had significantly improved outcomes. And patients with high coronary flow reserve who underwent bypass had slightly improved outcomes compared to patients who underwent PCI. This work is from Dr. Patel. She looked at myocardial blood flow reserve in a similar fashion to what was done with ischemia. So is there a threshold for myocardial blood flow reserve at which patients may benefit from early revascularization? So she demonstrated that there was a significant interaction between myocardial blood flow reserve and MACE associations with early revascularization. And what she demonstrated was that lower myocardial blood flow reserve was associated with more benefit from early revascularization. Again, this was retrospective data, so you can't infer causation, but you can infer correlation between the two. So instead of using ischemia, maybe you should be using PET and myocardial blood flow estimates to decide which patients undergo revascularization. So one more study. So this is a 57-year-old gentleman, newly diagnosed heart failure, LV ejection fraction 20 to 25% by echo, no hypertension, diabetes, dyslipidemia. He did a exercise stress 6 minutes on a Bruce protocol and developed only dyspnea. So this is his gated imaging. So here you have stress on the left, rest on the right. The ejection fraction, at least by SPECT, was higher than would have been classified by echo. Here we see the perfusion. So again, I'm showing you the attenuation corrected images: stress, rest, stress, rest, stress, rest, stress, rest. And you can see there is a completely reversible defect in the inferolateral wall. And if you were to use quantification, this was 23% stress perfusion defect with no rest perfusion defect, so 23% ischemia. So I'll leave it up to you if you were going to refer this patient for revascularization, but at least in my clinical practice, these patients still all go for revascularization. So he went for invasive coronary angiography, and you can see he has serial lesions in the RCA that were significant. And he also had some circumflex disease. But overall, large RCA with significant disease that was revascularized. So to put all of this in summary, retrospective data strongly suggested that patients with moderate to severe ischemia benefit from revascularization. And that was some older data from Dr. Hakemovich, but also several studies recently that have shown similar trends. But looking at the ischemia trial, which again, I think was very well done, there was a big difference in perioperative MIs compared to spontaneous MIs. And what they showed was that early revascularization, you paid the price of some upfront perioperative MIs, but maybe there's long-term benefit in terms of spontaneous myocardial infarctions. In the background, we know that patients with diabetes may be more likely to benefit from bypass. And other methods to guide revascularization may be able to select patients more accurately, and that includes quantitative assessment of perfusion, but also myocardial blood flow and myocardial flow reserve are potentially helpful. I wanted to touch briefly on viability imaging. So I think everybody's seen this slide before, but essentially what it shows is that viability imaging, there are several different modalities. They all have different sensitivity and specificity. The test that is the most sensitive for viability is FDG PET. The study that seems to be the most specific for viability is stress echo. So this is data from the STITCH trial, and this was looking at death from any cause in patients with ischemic cardiomyopathy who were randomized to either bypass plus medical therapy or medical therapy alone. And they demonstrated that bypass plus medical therapy had a long-term survival benefit in patients with ischemic cardiomyopathy. But again, there was an upfront risk with the curves eventually crossing over. So this was the 10-year follow-up data that was significant. So again, the calls to extend follow-up for the ischemia trial certainly seemed to be warranted. So what about viability in this study? So this was one of the studies that really did not support the use of viability. So what they demonstrated was differences in bypass and compared to medical therapy in patients without viable myocardium as well as with viable myocardium. And if you look at the potential benefit of bypass compared to just medical therapy alone, there was really no significant difference in patients without viable myocardium or with viable myocardium. But an important thing to know is that all of the viability in that study was done with either SPECT or stress echo. So this was a study that specifically looked at using PET to guide viability decision-making. The overall trial demonstrated very mild benefits of using PET to guide revascularization, but there was one site that did significantly better than the other sites, and they published their data independently. So this looked at data from Ottawa, and at least in their hands, using PET to guide revascularization decisions. So again, it's not that PET was used to pick out which patients sorry, this was done prospectively, is what I'm trying to say, is that PET was used to pick which patients would go for revascularization. So not all the patients in the PET arm went for revascularization, not all the patients in the standard arm went for revascularization, but it was really used to guide revascularization. So in comparison to the ischemia trial, where you're comparing revascularization, here this was a trial comparing imaging strategies. So again, in Ottawa, it seemed that using PET to guide revascularization improved outcomes in terms of cardiac events. So the summary of this, there's no significant difference in revascularization outcomes across viability when you use SPECT or stress echo, but outcomes may be better using viability in high volume expert centers, and in particular with PET. I wanted to touch briefly about cardiac sarcoidosis because this is an interesting interaction between diabetes and heart failure. So the study that's done most frequently to diagnose cardiac sarcoidosis is a FDG PET study. And patients with diabetes need a specific preparation. It's very well outlined in this article I'm referencing down here. But patients are asked to fast for 6 to 12 hours. They should hold their oral diabetic medications. And they're scheduled first thing in the morning. And during this study, they check a blood sugar 45 to 60 minutes after administration and give IV insulin to ensure that cells are taking up FDG. So this is a study of a patient with cardiac sarcoidosis that I don't believe had diabetes, but it's just to highlight some work we've done recently showing a different method to quantify cardiac sarcoidosis that might have improved diagnostic accuracy compared to visual subjective interpretation. So overall, what we've talked about is population trends in heart failure, diabetes, as well as nuclear cardiology. I tried to highlight that the yield of SPECT and PET are significantly higher in patients with heart failure or diabetes compared to the overall population. Either regional perfusion or myocardial blood flow and myocardial flow reserve can provide risk stratification in patients with diabetes, non-ischemic cardiomyopathy, ischemic cardiomyopathy, HFrEF, HFpEF, really everybody. And although the ischemia trial was negative for the primary outcome, there may be benefit of using SPECT to target in terms of reducing spontaneous myocardial infarctions. I'm happy to answer any questions you may have. Also, feel free to send me an email if you have any specific questions about the presentation.
¿Cómo estás, doctora Isabel Carvajal? Gusto saludarte.
Creo que ahí estoy, ahí estoy. Muchas gracias. Si podemos activar al doctor Giancarlo también, por favor.
Mucho gusto.
Buenas noches a todos. El doctor Miller está por aquí. No lo veo. Hi, Dr. Miller, are you there?
Ya está el doctor Carlo también ya activado, ¿no?
Gracias. Buenas noches con todos.
Estamos esperando al doctor Miller que lo pueda activar.
El doctor Miller, a ver, déjame validar si ya está registrado. Igual si quieren podemos ir, que vayan levantando la mano los que vayan a hacer preguntas y les vamos abriendo el audio y el video, si le parece, doctora.
Ok, perfecto. Parece que ahorita unos problemas de conexión con lo del doctor Miller. Él de hecho grabó su video, pero como les dije ahorita en el video iba a responder preguntas. Entonces, mientras podemos ir nosotros comentando algunas. Si gustan levantar la mano, igual que la vez pasada, levantar la mano y el host les va a dar autorización para el audio, para que puedan hacer sus preguntas en alto. Pueden hacerlas, por supuesto, en español y nosotros se las pasaríamos al doctor Miller en cuanto esté en inglés y las vamos comentando nosotros.
El doctor Horacio Sánchez le vamos a dar el audio y el video para que pueda preguntar. ¿Ya tiene audio, doctor Horacio?
Bueno,
Listo, doctor.
Hola,
un patrón,
Buenas noches.
gracias. Buenas noches a todos. Un patrón balanceado en medicina nuclear en un gamagrama con Sestamibi, con patrón balanceado, puede que demostremos viabilidad, es suficiente para justificar una revascularización completa en arterias que tienen lesiones significativas angiográficas o medidas por ultrasonido o reserva coronaria, sería mi pregunta.
Ajá.
O irnos a un eco de butamina para demostrar viabilidad. ¿Qué es lo que pesa más?
Ok, mire, en el patrón balanceado en medicina nuclear, ya sea que lo vea con un SPECT de perfusión miocárdica o con un PET, el patrón balanceado, la característica es que no se van a ver defectos en la perfusión. Vamos a tener algunos otros datos indirectos, como una prueba que tenga cambios en el ST, sobre todo si es con estrés farmacológico. Puede haber dilatación isquémica transitoria del ventrículo izquierdo, captación del ventrículo derecho en el estrés, captación pulmonar, caída de la fracción de eyección, del reposo al estrés, aturdimiento en el movimiento, que se aturda la pared, que existe hipocinesia o incluso disinesia, y también encontrar algunos datos de asincronía de la contracción, si se tiene el software para poderlo revisar. Pues cuando tenemos todos estos datos que nos suman, aunque existe una perfusión que no se identifique un claro defecto de perfusión, es cuando estamos sospechando de una isquemia balanceada. Ahora, cuando existe enfermedad de las 3 arterias epicárdicas, importante enfermedad obstructiva, y que existe defectos serios o isquemia severa de la perfusión, por el hecho de tener isquemia, ese es un criterio de viabilidad. Cuando nos auxiliamos o le sugerimos nosotros al clínico que se vaya a auxiliar con el ecodobuta, es cuando por los estudios de medicina nuclear no hay evidencia de viabilidad. Como en un estudio de talio, en donde existen zonas importantes de infartos transmurales y que al estrés no hay evidencia de isquemia. Son zonas de tejido que por nuclear, si en el talio no existe redistribución, podríamos pensar que es tejido muerto ya, que no tendría ningún beneficio después de la revascularización. El talio en este caso tiene muy mala especificidad, alrededor del 50%. Por lo tanto, si es un estudio negativo para viabilidad en talio, pues no podemos realmente estar seguros que sea negativo y que no exista viabilidad. Y ahí es cuando nos apoyamos o sugerimos un ecodobuta porque suple esa falla que tiene el talio. Creo que con eso contestaría su pregunta, doctor.
Sí, doctora, solamente le digo que es que a veces pedimos los estudios de gammagrafía,
Ajá.
una para demostrar isquemia y otra para demostrar viabilidad. Entonces, en un contexto de revascularización y diabético, ya que ya tenemos el paciente cateterizado con lesiones coronarias demostradas, para usted, ¿qué pesa más? Si yo le pido un estudio de viabilidad, o el cirujano, con la idea de demostrarle al cirujano que vale la pena revascularizar a ese paciente.
Sí, le entiendo, cuando tiene lesiones importantes. El estudio lo puede pedir talio empezando por estrés, porque ahí tiene el beneficio de obtener tanto isquemia como viabilidad. Se hace el estrés, una redistribución de 4 horas y luego se puede hacer una redistribución de 24 horas. En las primeras 2 imágenes ve el grado de isquemia que puede desarrollar el paciente y en la última imagen ve la viabilidad. El paciente tiene un infarto no transmural y eso lo vemos en las primeras imágenes. La definición es que al ser no transmural, eso es tejido viable y por lo tanto valdría la pena la revascularización. Si es un paciente que tiene isquemia, aunque sea ligera, también es un tejido viable y también el paciente se beneficia de revascularización. En donde queda la duda es cuando vemos en la perfusión infartos transmurales sin isquemia, con fracción de eyección reducida y aunque tenga anatomía muy compleja, ahí sí tendríamos específicamente nada más que ir a buscar viabilidad. En el caso de tener talio, pues sería con eso, si no tiene acceso a PET, pero el PET, que es actualmente el gold estándar, vemos nosotros en el instituto muchos casos de pacientes que con talio, grandes infartos de más del 50% del corazón, el talio sale negativo y a la hora que le hacemos el PET, completamente positivo. Entonces, se puede auxiliar del ecodobuta si no tiene acceso a PET, y si no el PET con FDG.
Le agradezco mucho, doctora, y a todos.
Con mucho gusto.
Gracias.
Vi ahí otra manita levantada.
Y había otra pregunta del doctor Josué, pero creo que ya la bajó.
Ok.
No sé si alguien más tuviera alguna pregunta. ¿Nos puede ayudar con la mano levantada, por favor?
Bueno, de los muchos datos que nos dio ahorita el doctor Miller, en el reciente congreso del americano de la Sociedad de Cardiología Nuclear, Americana de Cardiología Nuclear, que fue hace unos días, hablaron mucho de este punto en guiar la revascularización por reserva de flujo, no tanto por el grado de isquemia, o incluso, sí, pues por el grado de isquemia en SPECT o PET, que fue uno de los puntos que mencionó ahorita el doctor. Y también hicieron el mismo comparativo, un comparativo muy similar en cuanto a los hallazgos encontrados en el Ischemia Trial, y que ellos no están incluyendo el PET entre sus criterios de inclusión, solo SPECT, y con un grado alto que fue el 10 mayor de 10% de isquemia, cuantificada por score, que eso también, los scores del SDS, que eso causó mucha controversia en el Congreso, porque nada más era un solo parámetro, no cuantificándolo por TPD o por Extend o por el isquemia, que es el change que te da el programa también, solo por score, y que ese está muy afectado por el reconocimiento de bordes y por cosas externas, captación externa, si delimitas bien o no. Entonces, bueno, fue bastante controversial y evidenciaron también con más estudios muy similares a estos, los muchos beneficios y parecía que eso sería el futuro o de los próximos trials que se van a programar, pues revascularizar en base a cuantificación de flujos y a reserva de flujo, que va a ser ahorita lo nuevo. Bueno. Doctor Rojas, ¿algún comentario, alguna duda que haya leído por ahí?
Bueno, gracias, doctora. Bueno, sí, justamente lo que usted estaba comentando sobre la revascularización guiada por cuantificación de flujos, ya existe algunos antecedentes como no guiada por estudios no invasivos, sino ya guiada por pacientes tratados con angina, pacientes guiado la revascularización o el tratamiento médico, ya guiado por lo que es la cuantificación, vendría a ser por pruebas invasivas de las alteraciones funcionales, como el estudio Córmica, que ya tenemos ese antecedente, pero tenían algunas deficiencias estos estudios, que eran muy pocos pacientes enrolados y que también solamente se valoraba una sola arteria para que las valoraciones funcionales invasivas. y ya teniendo estudios ya un poco no invasivos, como el estudio de PET-CT para la cuantificación de flujo, la reserva de flujo miocárdico, ya nos podría valorar lo que es los 3 territorios. Entonces, ahí el cardiólogo o su médico tratante podría ser un poco, ser guiado lo que vendría a ser por alteraciones funcionales que causan estas lesiones coronarias en las epicárdicas, o también descartar algunos tipos, lo que es las disfunciones microvasculares, o también poder otros diagnósticos diferenciales.
Otro de los puntos específicamente en pacientes diabéticos, que es lo que mencionó el doctor Miller, la cuantificación de flujos y que hay evidencia suficiente por PED hasta este momento, el beneficio que le da a los pacientes incluso asintomáticos. En pacientes asintomáticos, con diagnóstico reciente o con diagnóstico de ya tiempo, pero asintomáticos de cardiovascular, si existe alguna disminución en la reserva de flujo miocárdico, este solo valor, aunque no tengan isquemia, este valor les está confiriendo mayor mal pronóstico para muerte de origen cardiovascular que si no lo tuvieran. ¿Okay? Entonces, la reserva de flujo miocárdico es actualmente el valor independiente de más peso pronóstico para desarrollo de MACE y de muerte de origen cardiovascular en pacientes diabéticos asintomáticos. Bien. Ok, pues ya son las 9 de la noche. Si no hay alguna otra duda, creo que damos por terminada la sesión.
Muchas gracias, doctora Carvajal y doctor Rojas.
Gracias.
Creo que les iban a poner ahorita la imagen de la sesión de la próxima semana.
Correcto. Estará con nosotros el doctor
Jerome Bax, ya previo a la inauguración formal del Congreso, que también empieza la próxima semana. Están todos invitados, aún se pueden inscribir. El doctor Jerome Bax es uno de los coordinadores y directores del curso. Participa activamente tanto con el doctor Alexanderson como con la doctora Meave en la planeación de las pláticas y en la organización en general. Y va a estar bastante activo durante el desarrollo de los 2 días del Congreso. Bueno, él empieza con esta plática. La próxima semana son excelentes pláticas las del doctor Bax, no se la pueden perder, se las recomendamos mucho. Bueno, sin más, lo esperamos el próximo miércoles, en vísperas del inicio del Congreso formal, para el día viernes. Gracias a todos. Buenas noches.